Hey guys, welcome back. This is Dr. Russell Linville again, going over post-operative treatment and progression of the knee, part 2. Let's dive right into it. Ligamentous pathologies. We're looking at the surgical intervention and rehab considerations following an ACL, PCL, or PLC reconstruction, MCL repair, multiligamentous reconstruction or repair. We're going to dive into the big dog first, the ACL reconstruction surgery. Let's do some anatomy. The ACL is intracapsular but extrasynovial. This is because it's wrapped in a sheath, kind of sitting in the center of the knee there. So this is why injury to it is so hard to heal, right? It's kind of by itself, wrapped in its own individual little sheath. The normal ACL serves an isometric function, meaning it maintains a constant length as the tibiofemoral joint moves through normal knee motion. The ACL originates on the posterior lateral femoral condyle and it inserts anteriorly on the medial tibial plateau. So it goes from top to bottom and it goes from back to front. There are 3 distinct bands: the anteromedial band, the posterolateral band, and the intermediate. And the reason these are important is because surgeons try to recreate these bundles or these bands of tissue to try to get as anatomically correct to a normal ACL as possible. And that proves to be very, very challenging. The function of the ACL, it restrains anterior translation of the tibia, prevents hyperextension of the knee, and acts as a secondary stabilizer to any valgus stress. The primary valgus stabilizer is the MCL. It controls rotation of the tibia on the femur and the infemoral extension between 0 and 30 degrees, and that's responsible for that screw-home mechanism, so it stabilizes during that. As far as ACL injury goes, you can have 3 different grades. Up to 25% of the fibers torn, or if there's less than 5 millimeters of anterior translation, you're a grade 1. Grade 2 is between 25 to 75% of the fibers torn, a 5 to 10 millimeter translation, and then grade 3, it says complete tear, but I'd assume anything over 75% we would consider a complete tear just due to the destruction of that tissue, and then greater than 10 millimeter anterior translation. Epidemiology, this number is probably more, but there's Bainon did a study in 2005, so we're talking about 11 years ago, 100,000 injuries per year. Females are greater than males, and this is important because there could be some neuromuscular control issues and then some just skeletal differences between males and females that puts females at increased risk. And this risk is seen in the literature anywhere from 2-to-1 ratio or 8-to-1 greater ratio females to males. Gender differences in ACLs are multifactorial and may result from a combination of neuromuscular, biomechanical, and structural or hormonal factors. Biomechanical factors can be addressed through correcting movement patterns and with ACL prevention programs. So a lot of soccer clubs and soccer teams are doing ACL prevention programs because there's a huge epidemic in youth female soccer players due to their poor neuromuscular control and then maybe their structural setup that they might be at increased risk. These programs have been shown to effectively decrease the number of ACL injuries in both males and females, and may even provide improvements in performance, and that's because they do a lot of plyometric training and strengthening. So the ACL mechanism of injury is usually due to valgus and external rotation applied to the knee with the foot planted. It is typically a non-contact injury, and if we look at the picture on the right, the top picture, you can see that skeleton is kind of going into femoral adduction, knee abduction or valgus stress to the knee, and then ankle eversion or external rotation of the tibia. The picture at the bottom right, I believe, who is that Cardinals player? His name's not coming to me right now. I think he's a safety, but anyways, you can see how he has gone into this position of no return, as we call it. That is the ACL nightmare zone, and he is not being contacted by that player, but you can tell he is already tearing his ACL. And as I'm saying that, I remember his name is Tyrann Mathieu, I think. So we want to make sure we keep our patients out of this position. And if you notice them doing squatting and exercises like that, you have to address that. That's usually due to hip weakness, and in this guy's case, it's just due to poor luck. Here's why the female bony anatomy might predispose them a little bit more to an ACL injury. As you can see the picture on the left, the two girls, pelvic position matters. If you have femoral adduction in a closed chain position, that puts your knee at more valgus stress. But not only that, compared to the male, the Q angle, or the angle between kind of the mid patella to the to where the femoral acetabular joint is, that angle is greater in females, and you can see how it just naturally puts them into more of a valgus type position. So injuries that can be associated with ACL disruption, we can have ligament injuries, and obviously the MCL due to valgus stress placed on the knee. You can also have LCL or posterolateral corner or PCL injuries if it's a contact injury or if there's hyperextension involved. There can also be meniscal and articular cartilage damage, and as we talked about in the previous lecture, they would address these during surgery as well, but the ACL would probably be the biggest surgical component to undergo at that time, unless they have like a meniscus repair or a microfracture. So you want to make sure you address which surgical intervention takes precedence when you're trying to rehab your patient. But meniscal damage frequently occurs at the time of an ACL injury, and the incidence actually increases in patients who do not undergo reconstruction, and this is due to the chronic instability of the knee. If you lose the stability the ACL provides, then the femur and tibia rub together a lot more in ways that shouldn't, which can create tearing of the meniscus. Meniscal injury associated with ACLs is anywhere between 15 to 40%. And then in a 7-year prospective study of patients who had acute ACL reconstruction, 2/3 of those with a concomitant meniscectomy developed radiographic evidence of OA, compared to 11% of patients who did not have a meniscal injury. So this is why taking care of the meniscus and protecting it early after an ACL is important. Also, bone bruises happen, and several studies suggest that 80% or more of ACL injuries have an associated bone bruise in the lateral compartment. This is just due to the compressive forces that happen with that valgus stress. The implication of this bony injury most likely caused by impaction between the posterior aspect of the lateral tibial plateau and the lateral femoral condyle during displacement of the joint. As far as timing of your ACL reconstruction, it used to be thought that you want to have surgery the same week, and this is just to restore normal anatomy as soon as possible. But I like this picture on the right of this tattoo because it's just the timing of knee surgery, right? It's pretty classic tattoo. Shelbourne and Patel, they looked at this timing, and it should not be measured in absolute terms from the onset of initial trauma. Basically, patients need to have excellent range of motion, little swelling, good leg control, or neuromuscular control, and an excellent mental state before surgery had good results, whether it was early or delayed. They really stressed that preoperative range of motion was equal to the opposite side, including hyperextension, and minimal knee swelling were much more important than whether the reconstruction is performed early or late. This was seen in 2 subsequent studies. Surgical techniques. There are a lot of choices. You can choose between an autograft or an allograft. The most popular autografts, or tissue that's harvested from yourself, is the bone patellar bone autograft, where they take the middle third of the patellar tendon, and they use that, and they harvest the middle third of the patellar tendon, but they stitch the outside 2/3 back together. There are complications with that. There is hamstring autograft, where they take either the semimembranosus, semitendinosus, and use that as a graft. Lesser used in autografts is the distal quadriceps tendon, which are starting to use more, and I think that's due to trying to decrease patients' anterior knee pain. Usually, because this is a bone patellar bone autograft, they take bone from the inferior angle of the patella, and they take bone from the tibial tuberosity, so that creates some bone pain that could be long lasting. I think this quadriceps tendon graft tries to eliminate some of that. Basically, autografts offer improved outcome scores and greater patient satisfaction compared with allografts. They're preferred in young, active populations, and this is due to the increased tensile strength. These people can be much more active. If you have an older patient, you might want to look at allografts because we're not damaging another site to create the graft. So they'd use it from cadavers. Typically, they'll use an Achilles tendon from a cadaver. The allograft is sterilized. It's specifically irradiated and has been shown to affect outcome measures and is a valid option in older, less active populations. So what choice in autograft? Was one better than the other? Evidence showing that bone patellar bone autograft shows greater improvement in stability of the knee than hamstring. However, clinical scores and rate of failure does not differ. And then bone patellar bone autografts are also associated, like I said, with that increased anterior knee and kneeling pain. But the hamstring autografts have long-term effects on hamstring strength. Obviously, if we're cutting out hamstring muscle, that side was likely going to be weaker for the majority of your life compared to the non-surgical side. Ligamentization, of the graft. This is how soon does your graft turn into a ligament, right? Because we know it's not a ligament; it's either a tendon or some other sort of structure. Does it turn into a ligament? There's no definitive data on when the graft becomes secure. The best estimate is between 18 and 24 months. It's at its weakest point about 2 to 5 months out. So if you're doing therapeutic exercise with someone and you're trying to work on cutting and running and jumping activities, that might be too much for them at this time if they have poor knee stability. Single versus double bundle technique. There's several surgical techniques. I don't want you to get caught up on that. I just want you to kind of understand some of the precautions that go along here. Long-term follow-up on these techniques show comparable results. Anatomic reconstruction may be more important than the number of bundles utilized, meaning you want to get your graft site as close to the original footprint of the ACL as possible. You don't want to be a millimeter or two off in either direction, anterior or posterior, as to where that graft should go, because that could really affect the stability and function of the knee. So, ACL reconstruction, are we doing a good enough job? That's a great question, and here's why. Athletes with prior ACL injury are at increased risk of future ACL injury. This is seen in several studies. There's a 6 to 25% re-injury rate. 15% of those who return to sports within 7 months suffer a re-tear. That is way too many. So if you can just get past the 7-month time frame, you have a less likelihood of re-tearing your ACL. And I think that's just due to you have more time to strengthen, you more time to train plyometrically, progress back into your sport rather than rushing back into it. The risk increases in younger athletes less than 20 years old. The re-injury rate in these athletes is 6 times greater than older patients, and the contralateral injury is 3 times greater. I also saw a study where a typical risk for an ACL injury is about 1% in all population. If you have torn your ACL though, you are at a 4% risk for tearing the contralateral side. So we got to make sure if you're working with a patient with an ACL tear and they're about 8 months out, you also have to make sure that other side looks good in terms of function and stuff, because they're at increased risk now for tearing that side. In cutting and pivoting sports, the re-injury rate is about 4 times greater, and the contralateral injury is 5 times greater. It's kind of like we just mentioned. And is there a family history involvement here? Like if your dad tore his ACL, does that mean you're at a greater risk? Well, it looks like there's about a 2 times greater risk, and this is probably due to anatomical similarities and biomechanical faults in movement patterns. Re-injury rates, I'll let you guys pause the slide here and go over this. I don't want to draw this out too much, but I do want to look at the second bullet, which is returning to sport. 33% attempted sport at pre-injury level 1 year after ACL reconstruction. That's only a third attempted to return to their sport. 64% return to their prior level of sport at 5 years. So still, a third of patients, even 5 years later, never return to their prior level. And then there's a 77% sports disability in 5 years, meaning they basically stop playing after 5 years. Multifactorial, this is due to people's impairments, their function, and then big-time psychological factors returning after an ACL injury. When you have an unstable knee, and I can speak from experience, so I tore my knee in college. I was a college baseball player, and there was a psychological barrier to getting back on the field and playing because you just don't trust that knee if you're not all the way there. So this is where physical therapists can come in and do a great job of, one, patient education, and then two, really challenging them and getting them confident in using that knee again. You know, we went over the Shelbourne study last time that went over ACL reconstruction, 11-year follow-up, looking at arthritis. There's some other studies too. 14-year follow-up by Baranius in 2013 showed 3 times the increased risk of OA in the surgical side versus the uninvolved. And if you had a meniscus resection or a partial meniscectomy, this was a very strong risk factor for OA. At 20-year follow-up, if the patient didn't have surgery on their ACL, 90% or greater have OA. But if they did have surgery and is considered good surgery, those patients also had greater than 90% of OA. So take that for what it is. If you have an ACL tear, you're going to have arthritis. That's just what the numbers are telling us. So chondral medial meniscus injuries seem to have the greatest effect on long-term predictor of OA. Here is an ACL reconstruction rehab timeline. This is what I use. This is kind of the time frame and mindset that I try to get my patients into. I see a lot of ACL patients, and basically what we'll do is we'll write on a sheet of paper, we'll write this timeline out, and I'll have them try to fill in their goals of when they want to do certain things. This is really helpful. It gets patient engaged and involved. But let's briefly go over the phases here. So phase 1 is all about protection. That's weeks 0 to 6. Phase 2, you're trying to work on muscular endurance, weeks 7 to 12. Phase 3 is when you really start getting after some strengthening, and we're trying to do some hypertrophy here, really build the muscle, work on neuromuscular control. Phase 4, we're now 5 months out at 20 weeks. This is when we can start to return to sport spectrum. We can start doing things like light plyometrics, progressing that dynamic balance, multi-plane movements, agility, and that sort of thing. Anytime before that, you're really being risky with a re-tear, unless that patient is just a stud. And then 7 to 9 months is when I tell my patients they can return to play. I always tell them 9 to 12 months because I don't want to get their hopes up, but we know the research shows that if they can at least get to 7 months, that they're at, they probably will be okay, but at that time, when they do return to sport, they're probably going to wear a functional ACL brace, which is a carbon fiber brace that's fit to their knee that will provide a little extra stability. And actually, the research in that is not conclusive. There might not be added stability, but it might aid in proprioception, which then increases their ability to be stable on that knee. Woo! Good work on the ACL. Now let's get into the PCL. Posterior cruciate ligament. We'll look at the anatomy. Just like the ACL, it's intra-articular but extrasynovial because of that synovial sheath we mentioned earlier. There is an anterolateral and a posteromedial bundle, and this is exactly opposite of the ACL, which was anteromedial and posterolateral. The meniscofemoral ligaments originate from the posterior horn of the lateral meniscus, and they insert onto the medial femoral condyle anteriorly. This is called the ligament of Humphrey, and posteriorly the ligament of Riesberg to the PCL. This is why the meniscus and PCL have a huge connection here. They're all connected. The PCL and the meniscofemoral ligaments combine to make up the PCL complex. And those meniscofemoral ligaments, those are secondary stabilizers of the knee against posterior tibial translation. So we need those and we like those. The posterior cruciate ligament surgical considerations, basically if you're suspecting someone has this injury, you're going to do a posterior drawer test. It's probably the best, most valuable test in evaluating the PCL. You want to make sure that they start in neutral translation though, because if they have a torn PCL, they might be sagging backwards anyway, and you go to press more and they don't have any more space to go. So see if you can anteriorly translate them first and then posteriorly translate them and compare it side to side and see what you think. With any suspicion of a PCL injury, the entire knee exam should be heavily scrutinized because isolated injuries are very rare. This too, to all those structures, as you notice on that last slide, that are close to the PCL, those can get damaged too, and that's when we start talking about a posterolateral corner assessment. So, like we just said, isolated PCL injuries are rare, so do I need surgery on the PCL? If it's isolated and it's torn, do I need surgery? Because there's a lot of other structures that provide support. Well, there's Shelbourne again, and then Muthu Karupa. They followed 215 patients for 8 years with isolated PCL injuries that were treated conservatively. Subjective scores did not decrease with time, so they still had basically reports of dysfunction. In addition, no risk factors could be identified that would help determine which patients would develop loss of knee function over time. The study was weighted towards patients with grade 2 laxity or less, so we're talking about a grade 2 tear or less, not a complete tear. Patel followed 57 patients with PCL isolated injuries for 7 years, and there was no correlation between the grade of PCL laxity and their subjective scores. Plain radiographs did show medial compartment OA, though, in all grades. There are a couple surgical techniques that people can do. There's a transtibial technique, and then there's an open tibial inlay technique. And from my experience, that open tibial inlay technique is more popular because it's less risky, and I think there's less re-tears. And the reason is because in that transtibial technique, you can see that what they call the killer turn. I think that can if it's not tensioned right, can put a lot more stress on the PCL. The problem with the PCL is it's really hard to get it anatomically correct, especially if there's damage to that area. So they do their best, but if you have someone with a PCL tear, they're probably not going to have a normal knee. Let's talk about that posterolateral corner, because that is important. There's several studies that have evaluated the biomechanics of combined PCL and PLC injuries and the reconstructions thereof. Untreated posterolateral corner injury may result in increased loads in the PCL graft and subsequent PCL graft failure. So if you go in and you do a PCL reconstruction, but you don't address the posterolateral corner, that could lead to graft failure of the PCL reconstruction. Further, in the setting of a combined posterior cruciate ligament and posterolateral corner injury, this gets really confusing, so you got to look at the letters here. Reconstruction of both structures better restores intact knee kinematics and native PCL in situ forces. So if you have a PCL tear, check the PLC and reconstruct both is essentially what we're saying. I'll let you pause it here. You can look at different surgical techniques. I'm moving on. PCL and PLC rehab considerations. So for the PCL reconstruction, you're going to do partial weight bearing for 6 weeks. The brace is locked at 0 degrees during the 6-week time frame. You can start doing partial weight bearing till weight bearing is tolerated from week 7 to 12, and then not until week 9 to 12 is the brace unlocked, and that's only to 0 to 90 degrees. You got to remember what is being reconstructed here, right? So as far as range of motion goes, you can do passive knee flexion, but you don't want to do wall slides. And why? Is because that puts them right into that position of that special test, that posterior glide test. At 7+ weeks, you can progress to full range of motion, but do it safely, please. And then posterolateral corner reconstruction. This is a little more involved because there's a lot more structures, but 0 to 6 weeks, non-weight bearing, brace and full extension, except during range of motion exercises. Quad sets and patellar mob should be started immediately. Hamstring sets should be avoided in the first 6 weeks to minimize the risk of the graft stretching out. So just remember that. There's a lot of structures that share fascial sheaths back there. If you're contracting the hamstrings violently, you're going to stretch out some of those grafts and cause some real damage to the surgical site. After 6 weeks, their weight bearing is tolerated. At this time, if they demonstrate good quadricep strength, they can be discontinued from the brace. Now, this goes against what the more conservative rehab protocol is on the left, where they want you in the brace up to 12 weeks. I would probably caution more on that. And unless they're a stud athlete, they probably won't have the strength in their leg to be out of the brace at that time. Biking exercises can be added as soon as they have 100 degrees of knee flexion, but sport-specific training is started at around 4 months, and we're actually talking probably more like 6 months. Those sports activities are delayed until normal range of motion, strength, and stability is achieved. Now let's talk about the MCL. You can do a repair or a reconstruction. Basically, the surgical treatment is reserved for patients who have persistent valgus laxity or rotary instability or chronic medial instability associated with a cruciate ligament injury. If the medial injury does not tighten during the 4 to 6 week brace treatment, surgery may be considered. And then post-operatively, the knee is protected with a hinged brace to allow careful protected range of motion and partial weight bearing during the healing process, and that is of at least 6 weeks. Rehab considerations following surgery, weight bearing, partial weight bearing with crutches for the first month, and then this is a progressive knee flexion range of motion precautions. And that's due because with increased knee flexion becomes increased stress on the MCL. So we want to make sure we respect that. The brace, the surgeon, it's really up to them. If it's an isolated MCL, repair, reconstruction, sometimes they don't brace them. Majority of the time they do. It's typically 0 to 6 weeks, and the brace unlocks 0 to 90 degrees so they don't damage the surgical site. But is surgery needed with an MCL injury? There's really good research on non-op treatment for isolated MCL injuries. Patients with superficial MCL injuries, treatment in a brace with a protected range of motion and rehab allows most of the grade 1 and 2 lesions to heal in approximately 2 to 6 weeks, as long as we're protecting that range of motion. Treatment of grade 3 lesions, although may recommend operative treatment, but non-operative treatment also has high success rates, and those are seen in the Moeller and Houston studies, and those are some references from those studies that show that. So let's talk about the multiligamentous knee injury. Just look at the x-ray in the top right. That guy has a dislocated knee. I mean, it's obvious. And all the structures are now destroyed. So what the heck do we do? I mean, I really don't want that to be my knee. The picture under that is of Marcus Lattimore, who was a running back for University of South Carolina. And I was in Greenville, South Carolina, starting my residency near the time of this injury. And this was all over the news, and all the docs and stuff were talking about it, and it was just crazy. In 2001, I think, is Willis McGahee down playing for the University of Miami. You can see he's going through a similar knee injury where his knee is just getting hyperextended and destroyed. He has multiligamentous injury. The funny thing about McGahee is he actually took out a $1 million insurance policy on his body prior to that game, and he cashed in on it. And then later, he rehabbed it and went to the NFL and made more millions. So that guy is pretty smart business sense. Anyways, I digress, and we'll talk about these multiligamentous injuries just briefly. This is going to be something that is, as Skenzel reports, is a very challenging and complex clinical problem. There is serious risk of vascular and neurologic injury. And that's the main thing. If you're responding on the field, if you guys become sports PTs one day and you see this, you have to take into account that their nerves and their vascular supply may be damaged. I want you to pause it and read this quote by Skenzel, and then I want you to read actually the multiligamentous injuries article and clinical commentary that he wrote for the JOSPT in 2012. Now let's get into patellofemoral pathologies. We'll look at lateral release, quad tendon, and patellar tendon repairs, and then MPFL repair reconstruction. A lateral release is they're actually going to be cutting the lateral retinaculum. This area gets tight due to muscular imbalance, poor biomechanics, or bony anatomy abnormalities. And because of that, the patella can begin to track laterally. Over time, if the strain is great enough, the medial tissues resisting the lateral pull of the muscles become painful. So if you keep pulling it laterally, the stuff on the medial side gets really painful, right? Just to that constant pull. What they do is they go in, and you can see in this illustration that they've released tissue. And they've just cut that tissue so that there's not as much pull there. They've decreased the tension. The x-ray, that's a sunrise view, or a merchant view some people call. And you can see the trochlear groove there where the patellar glides in. And if you look on that left knee, this is looking from the feet up. The left knee, you can see how laterally that knee is tracking. So the medial structures are either torn or really painful, or the lateral kind of condyle of the knee there, the lateral trochlear groove, is now becoming almost rubbed raw due to friction forces. Rehab considerations: this is an arthroscopic surgery. They come out, their weight bearing is tolerated, full range of motion, no brace, strengthen the heck out of their hips. A lot of times people have poor hip strength and that they fall into femoral internal rotation, which might lead to this issue more so. Your patellar mobs will be focused on a lateral tilt. Here's another big daddy, the quad or patellar tendon repair. We couple them together just because the precautions are very similar due to the proximity of anatomy here. These tears often come in the form of one single traumatic event. There's typically a strong force, such as an explosive jump or in a landing, and those are usually the forces required to rupture the tendon. I had one guy that actually slipped on an icy deck, and his knee went into super hyperflexion, and he tore it there. Surgical repair reattaches the torn tendon to the bone. So patients do better if the repair is performed early after the injury. As we remember to ACL, that's not necessarily the case for an ACL, but it is the case for a quad or patellar tendon repair. An early repair may prevent the tendon from scarring and retracting in a shortened position, just like we know a Popeye deformity would with a biceps brachii tendon tear. We don't want it to retract. The goal of the procedure is always to restore the correct tension and positioning of the patella so that the fulcrum mechanism of the knee can be maintained for proper function. Rehab considerations: they're going to be locked in extension from 0 to 6 weeks, progress opening week 6 to 8. Weight bearing, partial weight bearing for 2 weeks. Weight bearing is tolerated after that, full weight bearing by 6 weeks. And this is where we protect their knee flexion range of motion progression, right? Because anytime you flex the knee, that's going to put tension on the surgical site, and we want to make sure that we don't do that too soon before they're ready. Now we'll talk about the medial patellofemoral ligament, and this is a ligament that can become torn if someone sustains a dislocation of the kneecap. And in most cases, the kneecap dislocates laterally, which would then put the trauma on the medial side. Because this MPFL acts as a check rein against lateral forces, there's so many structures on the lateral side of the leg and the knee that pull the patella laterally. This MPFL is really the only thing that's keeping it, prevents it from tracking laterally all the time. So this surgery is used to correct serious and recurrent dislocation of the kneecap. The surgeon reconstructs the MPFL to keep the patella in the trochlear groove, preventing that dislocation. Repair has a high failure rate. So if they go in and they just stitch this kind of back together, that has a very high failure rate compared to reconstruction. With reconstruction, there's a 95% success rate. So if it was my kid that dislocated their patella, I'd say, hey, let's do the reconstruction. Rehab considerations: no lateral patellar glides. That makes sense, right? If they just reconstructed the medial structures, you are not going to glide it lateral and put stress on those structures. Progressive protected flexion is also the name of the game here. Partial weight bearing with brace locked and extension for 3 weeks. Weight bearing is tolerated with brace locked and extension up to 4 weeks or 6 weeks, and then after that, full weight bearing. You're going to open the brace slightly because we're still protecting that. We're protecting the knee. We're protecting the forces that can go through a flex knee. So they're locked in extension for 6 weeks. You can open that to 60 degrees at week 5 for non-weight bearing exercises, and then by week 9 you want to wean them out of the brace. At the bottom there you can see the range of motion progression based on week by week stuff. Now let's look at some pathologies that are due to biomechanical or bony issues. We'll look at an osteotomy, tibial tubercle transfer, and fractures. So your high tibial osteotomy, this can realign the genu varus knee. So think of someone with really bow legs. This takes pressure off that medial compartment of the knee. It is a procedure known as the HTO. Basically, they take wedges and open the upper shin bone to reconfigure the knee joint into more of a valgus positioning. The weight-bearing part of the knee is shifted from degenerative or worn tissue onto healthier tissue. And then HTO generally considered a method of prolonging the time before a knee replacement. This is usually done in younger patients with pain resulting from the instability and malalignment of the knee. Here's what an x-ray looks like. You can see preoperatively how they're in that varus stress, and then postoperatively they have this like ORIF type of plate and structures, but what you'd see in the middle of those screws is the bony wedge, and that has then changed the configuration of the entire knee. So its indications are age 40 to 60. You don't want varus over 15 degrees because that's really hard to correct due to, just think of all the stress and put on all the other tissues that have been in that position for so long. Rehab considerations, weight bearing, non-weight bearing for 8 weeks, and that's for that, allow that bone to really heal. And then weeks 8 to 10, you'll increase weight bearing by 25% each week to full. And then the brace is locked in extension until excellent quad control is shown, and then you're wean out about week 6. And then range of motion, you can do full range of motion with these guys. Just respect their pain. This is a little more brutal and kind of like Frankensteinian procedure. This is the tibial tubercle transfer. So the tibial tuberosity is reattached to a different location. This allows the kneecap to move in a way that reduces stress and pressure applied on certain parts of the knee. This provides relief when there are symptomatic articular lesions or arthritis on the backside of the patella that may be unloaded when they do this transfer. Rehab considerations, weight bearing, I'll let you guys read this, but partial weight bearing, 2 weeks, progress to full. And then again, because we're involving the patella here and we're involving bone here, a really progressive brace program and range of motion program. Fractures, this is, we'll briefly go over this. There's going to be different protocols, but by this time in your, if you're a clinician and you work with a lot of postoperative patients and you see fractures and ORIFs of some of these things, you'll have an idea of what needs to be done when. But just remember, the patellar fractures and tibial plateau fractures, those are the most common. But if someone has a patellar fracture, you can't crank on knee flexion too soon because that could really stress the ORIF. If you have someone with tibial plateau fracture, they got to be non-weight bearing for a while to allow that bone to heal. So I don't expect you to know all these different types of fractures. I want you to know they exist. You won't get a test question on types of fractures, but you would get something on like weight bearing precautions and things like that. And maybe something in the lines of, would you push knee flexion very hard with a patella fracture patient? And I want you to know why you would not. So if we move on here, I really want to thank you guys for your time. You guys always do a great job with this stuff. I'm always open for questions, and you have my contact information, so please get in touch with me. It's been a pleasure working with you, and I hope that I have the option of working with you guys in the future. Thank you very much.